Hello, everybody. My name is Håkan Hamer. I'm the Executive Officer of the Nordic Society of Human Genetics and Precision Medicine. Welcome to this third webinar in our series. Samuli Ripatti from Finland will give today's talk. But before that, I will just say a couple of things. The first is that we will be taking questions after Samuli's talk, and you'll see that there's a place where you can enter questions at the bottom of your screen, and also that you can, I can't remember, can we upvote this time, Nico?
Yes, we can. Yes,
great. You can, if you find questions that you like and you don't want to repeat them, then you can upvote them, and we'll take those at the end of Samuli's webinar. And then after the question and answer session, then the panel will come in, and then you can continue to ask questions. And Samuli also has posed 3 questions that he was interested in having the group discuss, which we'll put into the Q&A bar periodically. I'll try to put them up as well before his talk, so you can think about them. Just before that, I will take a very quick take on a 1-minute tour of the Nordic Society. If you're not familiar with us, we have been meeting since 2018, but less often in the last year and a half, of course. We work on different aspects of building a Nordic research community in precision medicine and human genetics. And we do that through interacting with research funders, the research universities, Nordic Council of Ministers. A big part of what we try to do is inform people to create this community, and the webinar series is part of that. We have a legal working group that has already begun to work on some issues, and we'll be issuing papers. We send out a newsletter. It's semi-regular, but it's becoming more regular, and we are present on social media. Please visit our website if you'd like to keep up with Nordic research and policy news. That's we're beginning to put out more and more of that. And in particular, I wanted to just point to one thing that we posted just yesterday, which is we're going to be posting papers of the week, and we call them from PubMed on the weekend. And then I think on Tuesday mornings, you'll see papers published by as many of your colleagues as we can find. We'd love to have you tell us if we've missed papers, so that way it improves our search. We are on YouTube, and that is where you will be able to find these webinars after they happen, but we're going to create a place for them on the website, make it easier to find. And also what I've been doing little by little is as we find things, interesting lectures by people from the Nordic community about human genetics and disease, precision medicine. We've been collecting those. And so please, if you've given some great lectures that only a few people in your family or lab have ever seen, send us a link, and then we can create a good resource out there for everyone. Finally, coming up, we have in the plans our biennial meeting. We hope we could have it in person. We're also planning a COVID-19 Nordic response workshop. They may coincide. Our virtual journal club that I've been talking about for a while is actually going to happen soon. And we have a few webinars coming up. And I can't give you dates yet, but there's some teasers there. And I think that is all I have to say at the moment. So I think I should stop my share. Is that correct, Nico? And then I will be able to...
Yes, please. And we'll invite Dr. Ripatti to share.
Yeah, so I'm going to stop sharing, and then I'm just going to do a very quick introduction to say that our speaker today is Dr. Samuli Ripatti, who's the Deputy Director of the Institute for Molecular Medicine in Finland, FiMM. And he's also the Academy of Finland's Center of Excellence in Complex Disease Genetics. He's the director or leader of that, and he's a leader of the complex disease group at FiMM, and his research focuses on genetic variation and its relation to human metabolism and cardiovascular diseases. And now I can turn it over to Samuli.
So good afternoon, everybody. Many thanks for the invitation to present some of our work and the kind introduction from Håkan. So what I will talk today is about genetic risk and its use in disease prevention. That's the title. And that's a little bit different from what we have been doing most of our time in human genetics for the past 10, 15 years. And so where much of our activity has been going into genetic discovery. And here is a website where we now every 6 months publish about 3,000 plus genome-wide association studies and make them available for the whole community from FinnGen project. So if you click on r4.fingen.fi, you find the data release 4 results. And as you can see, if you look at the list there, this is the top list of phenotypes in the website, where with the order of how many significant or genome-wide significant loci, genetic loci we have associated with these diseases. There's plenty variations of around type 2 diabetes and cardiometabolic diseases. But in the column genome-wide sig loci, you see that there's for example 84 loci for statin medication. Some of them are something that has been reported in previous studies, and some are not. But this has created kind of a positive problem in the sense that we don't quite know anymore how to plot all of these results together. And here is an ongoing study that we have currently, where we looked at the cardiometabolic medication use, like those statin medication usage and other medication usage in our database, led by Tuomo Kiskinen, who's the serious man in the corner there. But it is really a challenge, a positive challenge, to try to illustrate the findings. And of course, it's a huge challenge for the whole community to follow up all of these findings, or at least even the most interesting novel findings in functional studies and different kinds of biology leading cues. So this is what the discovery part, or much of it, has come to. Pooling together large data sets and finding genetic loci. And if we contrast those to what are the tools that the clinicians at the other end of these diseases are utilizing, it's a very different world. So what they are looking at are typically these types of risk calculators, particularly for primary prevention. And here is an example of the SCORE, the European-led cardiovascular disease risk calculator that we all are sitting in one of the boxes there, and the more red the box, the higher the likelihood of fatal CVD event for assist. And then we are all put in there, and depending on the box we land in, then there may be some ideas on how should we lower our risks. There's also more developed versions of these types of calculators, like this one from Dundee, which is a wonderful manual risk score calculator using more or less the same input variables, and then you turn the circle and find where you are. So this is the reality. This is where the clinical world is in terms of the risk calculation. And what I'm talking about today is some of the ideas or some of the ways that we've been thinking of how to make these two worlds meet. Here's just for comparison, the American version of the risk calculator, which seems much more elaborate, but more or less works on mostly on the same variables as the previous two ones. And it's an interesting part of this guideline is that the guideline itself, when defining the risk categories of individuals, whether you're low risk or borderline risk or intermediate risk or high risk, they are really interested in individuals between 40 and 75-year-olds, more or less only. So if you're under 40, this doesn't give you much guidance, or if you're over 75, you're not interesting anymore when it comes to this particular guideline. So these are the tools. And if we go back to the genetic side, what do we want if we start out with coronary heart disease or coronary artery disease? What we know about the genetic background of the disease is that quoting the 20-year-old Andreas Finke's wonderful Danish twin study on cardiovascular disease or coronary heart disease mortality, genetic variation explains about 50% of disease risk variation between individuals. This came out from a bivariate frailty model that him and Anatoly Yashin put together for the estimation. In the genetic discovery side, depending on a little bit how you count, but it's the ballpark is that there's around 75, a little bit more maybe, genetic loci that have been associated with coronary heart disease risk. And then there's a good amount of rare high impact coding variants that have been identified either in those loci or in other genes that are related to the heart disease risk. The bigger question that has been posed is the risk driven by distinct driver mutations? That has been sort of the traditional way of thinking, that maybe all of the cases have their own driver mutation that cause the disease to happen, or is it the disease that is more of a blend of many genetic factors? And what I'm going to argue is that it's a blend of both, but definitely the many genetic factors on the right hand side of the plot is important as well, on top of the driver mutation type. So putting together the genetic information in coronary heart disease, this is roughly the timeline that we've been doing this. 11 years ago, we put together what we thought was a monster of a genetic risk score by combining 12 lead SNPs from genome-wide association studies at the time, and then we genotyped them in 2 Finnish cohorts and 2 Malmö cohorts from southern Sweden, and looked at how do they predict future cases of coronary heart disease. And this game has then been going on, and there's been updates on the number of SNPs, so that the latest ones actually take in the whole genome and model the dependencies within the genome to take it into account. And if we look at the UK Biobank data and look at the prevalent CAD cases there, the polygenic risk score, the top 1% of the score, putting together the genome variation, has about 5-fold increase in risk when we look at the UK Biobank European Ancestry Set. So that has been the state of the art in terms of turning these scores into risk evaluations. So what are we actually doing when we put together these scores? And this is sort of a schematic plot on behind pretty much all of these algorithms. So the input, so we want to calculate the risk for individuals such as ourselves here. And what goes into this calculation is that we take in the summary statistics or the odds ratios from a genome-wide association study. Then we need to somehow adjust, and these odds ratios give the weights for individual SNPs for the calculation and summation them for the polygenic risk score. But what we need to take into account, of course, is that the dependencies or the correlation structure in the genome is non-random, and that has to be either modeled in or filtered in when we utilize these scores. And the 2 papers there are 2 of the seminal papers where much of the later genome-wide approach for the modeling of the whole genome variation into these polygenic risk scores have been used and developed and tested. But there are of course question marks on how exactly to do that, and I'm posing a couple of these questions. So one of them is that, does it matter which GWAS summary statistics we use at input? And I quote here a paper by Sini Kerminen, who defended her thesis last Friday successfully in Helsinki, where what she did is she took the Finnish individuals from a nationwide study, looked at their height, and what you can see in the blue map there is that Finns, which is a well-known fact, is that in the southwest they are taller than in the northeast. So we have a clear geographical gradient in the height of the individuals within Finland. And then when what Sini did was calculate, based on a couple of different scenarios, a polygenic risk score for height. So doing the same thing that I showed in the previous slide, but doing it based on the giant consortium height, effect sizes, UK Biobank effect sizes, and then a FinRisk study effect sizes. This was an independent set of our test set though. And what you can see is that the giant polygenic risk score very much follows the height distribution in Finland, whereas the UK Biobank-based risk score, still there's a little bit of similarity there, but the effect geographically is much smaller, whereas again in FinRisk polygenic score, we follow the geographical distribution. But the real question is that, are these differences that we see between the three yellow-red maps here, are they due to differential statistical power in terms of building up the polygenic score? So is it really so that giant has so much more power that it captures the real gradient in height much better? Or is it actually residual population stratification? So because we know there's a lot of stratification within Finland, and maybe some of that has been gone into the giant summary statistics. And how Sini tried to differentiate between these two was actually to go back to these summary statistics and took those SNPs that do not in the original GWAS show any association with height. Because if there's signal there, then that must be something else than real signal explaining the height changes in Finland. And this is exactly what happened. So the red one here corresponds to the giant polygenic score. So these are SNPs with p-values in giant more bigger than 0.5. So no signal, there shouldn't be any signal. And this is the number of SNPs that she puts together in the polygenic score. When she takes 80,000 of such SNPs, she can explain about 3% of the height variation within Finland, even though she shouldn't be able to explain anything. When we took the FinRisk samples, even though these are not part of our test set, we could still explain some of the variation there. This is the giant without any fins there. And still we can explain something, much less than when we take out the fins, it works better, but there's still clearly residual stratification within the giant summary statistics here. Only when we take the UK Biobank data set that really don't, at least as far as we know, doesn't have anything to do with us Finns, there's no signal left. So in other words, we need to be careful when we combine these polygenic risk scores, and these types of population stratification issues need to be taken seriously there. Does it matter which algorithm we use to build the polygenic score? Here's an example from a paper that came out last month, where we looked for breast cancer. We compared 3 different polygenic scores, 3 different algorithms to put them together. The first one, 313, refers to a paper where there's about 300 SNPs that have been sort of experts picked up as a good set of breast cancer SNPs, combining the genome-wide associated SNPs and some of the well-known breast cancer-related rare high penetrant variants. And when we estimate the effect on hazard ratios for this particular polygenic score, this is the hazard ratio per SD. So for one SD, it's 1.45. And that's quite strong association on the polygenic score world. But when we change to a non-expert driven score, but rather LD-PRED algorithm driven score, modeling the whole genome information from the genome-wide association study, we clearly do much better in capturing the risk in this independent data set from FinnGen. And the third example then is a variation of this reweighting of the effect sizes for the genome-wide association study, and we can push the predictive power even a little bit further from the LD-PRED here as well. So in other words, it doesn't matter how you combine or which algorithm or how you utilize the vast amount of information in the input summary statistics from the GWAS studies, although it may depend a little bit on the disease or the prediction task at hand, which way is the most powerful in terms of putting these together. Okay, so going back to the coronary heart disease examples, one question when we try to start putting together the clinical reality and the polygenic risk scores that we have is the question, how does the PRS work in with the current clinical scores? And this is what we, together with the postdoc in our group, Nina Mars, started to work a little bit more than a year ago. So FinnGen is the database that we use, or data set that we use for these tests, where we have 500,000 Finns. That's the target population. It's still, the collection is still ongoing. We are a little bit over halfway now in terms of collecting the individuals. We have a genotyping array which is a variation of the same array that UK Biobank utilized, linking to the National Health Register data. And then this is a public-private partnership with industry and Finnish taxpayers funding. So this is the test set at which the linking to the registry data allows us to move from singular time points to really longitudinal setting, where we follow individuals up over the life course for the major health events, and we can utilize those to in our genetic studies as well. Okay, so for coronary artery disease, when we created the polygenic score, we took the whole genome common variation into account. We had in this paper from last spring, we had about 20,000 coronary heart disease cases there, and when we looked at the lifetime risks and the differences there between those with a lot of protective alleles, the blue or dark blue ones here in the polygenic risk score distribution, and when we compared to the highest end, 2.5% in the highest end, this is the distribution in the lifetime risks of the individuals. I have to say that this, for coronary heart disease, this may not be the most powerful risk score, because the input really came because we wanted to be safe for all the population stratification issues and potential overlapping samples. We utilized only UK Biobank to get the weights for the score, and I think you can do better if you're not part of the Cardiogram plus C4D consortium. Then what we did next was to combine the information that we had for the genome-wide risk with the clinical risk factors available from the data. And what we did was that we looked at the cases that we have in the data set, divided them into early onset CAD cases. In our case, we put the threshold in 55 years of age. And then we had the later onset. I mean, I wouldn't say late onset, but later onset of cases. And we looked at, played the game that if we had the risk score information, both for polygenic and the clinical risk score, how often would they have flagged that this case, if we had those earlier on available, how often we would have sort of captured them with the different scores. And what you can see here is that if we start with later onset cases, the clinical risk score has been developed in the way that it's actually very sensitive to find the high risk future cases here, with the idea that maybe we can sacrifice some of the specificity there. So the blue area is big, and this 10% is the range where both clinical risk and polygenic risk is high in the case, and 2.5% where those where only the polygenic risk was high. But it's a different ball game when we go to the earlier onset diseases, because much of the clinical risk scores have really been trained with middle-aged or older individuals. So they don't work very well for identifying early onset cases or individuals who are early, sort of in the younger age range. So you can see that the benefit or the additional value for identifying high risk individual of the polygenic risk score is actually quite substantial. And if we want to see the details, we calculated different kinds of indices in terms of trying to understand what is the false positive and false negative rates there. And one of them is the net reclassification index that shows that there's clearly a benefit of adding the polygenic risk information, particularly for the young people. But after all, these are mostly orthogonal pieces of information, so it really makes sense to pool both genetic and clinical risk factors together. So here's a COD risk. Red one has a high polygenic risk, blue one's high clinical risk, and these individuals have high both risks. And there's a clear dose response, same for type 2 diabetes, so actually even clearer effect for there. So it makes sense to look at this, not genetics isolated on its own and not clinical risk factors on its own, but rather looking both at the same time. And the same applies for many different diseases. In the paper, we looked at 5 different diseases, including also common cancers. And I'll show you a couple of examples of more details now on breast cancer side. So all of the diseases, the dynamics are roughly the same. There's clearly now a good amount of information about the risk in the genome, and we are pretty good at pulling it out there and estimating the effects there. Of course, in breast cancer has been the one of the model diseases where we started out, we as a community started out as the gene mapping in complex diseases, identifying the BRCA1 gene mutations first through linkage studies and then pinpointing the mutations there. But it is also a disease where there is again a clear polygenic component as well. And this is the GWAS from FiMM, and leading the pack are 2 highly Finnish enriched mutations in 2 well-known risk genes, PALB2 and CHEK2, but the variants, the frame shift variants that are leading the way there are highly enriched in Finland. So that gave us an opportunity to start looking how these individual high impact mutations work together with the rest of the genome or the polygenic load there. And this is a schematic plot on how they work, or where we are in terms of allele frequency in the population versus the effect sizes. We have the rare end of the risk variants or mutations, which are in population, very rare. We have sort of a set of, and this is a growing number of moderate impact, low frequency variants, and then we have the common variants with individually small impact, but when we start piling them together, their impact is actually a lot bigger. So that's the polygenic risk. And when we compare to the distribution of the polygenic risk now with the individual mutations that are clinically being tested routinely, this is where we are at least in the Finnish data. So when we are at the tail end, so this is now 0.25% at the top end. So that's a small fraction, but that's where the polygenic risk in our data is at the same level as the PALB2 when it comes to the lifetime risk of cancer. It's about 50% lifetime risk there. And the top 10% is on the same level, about 30% lifetime risk as the JEC2 mutations. And this, of course, this shows the risk for a carrier of an individual mutation or for an individual who is at the tail of the distribution. But its impact on the population level is, of course, much bigger for the polygenic or high end of the polygenic risk, particularly for the more moderate risk end. And here is the proportion. If we take 100 breast cancer patients and who carries what mutation or are in which part of the polygenic risk, you can see that out of 100, it's about 1.5 women who carry the high-risk mutations, BRCA mutations and PALB2. It's about 5 out of 100 that carry moderate risk mutation. But if you have the comparable size of polygenic risk, it's more than 20 women are there. So its population impact is much bigger than at least those mutations that we know right now. The polygenic risk operates also similarly for mutation carriers and non-mutation carriers. So here you can see the relative risks or hazard ratios in those at the lowest end of polygenic risk and highest end of polygenic risk in mutation carriers versus non-mutation carriers. And you can see that the effect sizes are almost exactly the same. So these are independent pieces of information, which means that we can easily utilize them or it makes sense to utilize them together. So this is what we did. So here's a graph showing where Finnish female population is in terms of their lifetime risk of breast cancer. It's about 15% or so, a little bit less maybe by the age of 80. If you're a carrier of JEC2 mutation, your lifetime risk is about 30%. If you have both JEC2 mutation and a high PRS, meaning that you're in the highest 10% of the PRS, it's about 60%. And if we go to the other end of the PRS distribution, you can see that with JEC2 and low PRS, the lifetime risk is point estimate is actually lower than in the population. So right now, again, our clinical reality treats everybody with the JEC2 mutation the same, where in reality there's quite a big distribution or difference in different parts of the JEC2 mutation carrier population. So how does the polygenic risk translate in terms of screening opportunities? So the Finnish screening system for women is the same for everybody. It starts at 50, then there's mammography screening, nationwide range mammography screening every 2 years for everybody. And the age 50 have been defined in the way that there's a 2% breast cancer prevalence in the female population at the age of 50. And when we look at our distribution of the polygenic risk score, that's where our average women are. So in the polygenic risk score, when we between 20 and 80% percentile of the distribution, there's 2% breast cancer prevalence. When we go to the risk side of the polygenic score, the 2% breast cancer prevalence comes 5 to 6 years earlier for those women. So definitely it would make sense if these data are available to start the mammography screening for the elevated risk women earlier. You could also argue that there is the protective side of the polygenic score, where the 2% prevalence comes more than 8 years later for this group currently. So we could think about whether these women should maybe come a little bit less often to the mammography, or have some other changes in the one-size-fits-all program. Okay, a couple of additional things that are important when it comes to the polygenic risk score. One of them is that everything I talked so far has been related to and applied and tried out in Finnish population. And Finnish population meaning that in Finland even sort of filtered for the individuals who have European ancestry, or who are part of sort of Finnish Nordic ancestry groups. How well do these methods now operate for different ancestry groups? And this is what we've been testing in Intervene Consortium, together with 7 biobanks, 1 million individuals and multiple ancestry groups for 4 diseases here. You can see that for coronary heart disease, type 2 diabetes, there's kind of a trend there. So the European, this is again, the scale is that this is the odds ratio for 1 standard deviation change in the polygenic risk score. So you can see that the Asian ancestry, meaning here South Asian and East Asians pulled together, you can see that the risks are a little bit lower than Europeans, but not that much. But when we go to the red boxes, or the African ancestry individuals, it's clear that our current tools with the European dominated GWAS in the background do not really work that well, at least maybe for type 2 diabetes, but definitely not for breast cancer and prostate cancer. Then sort of the natural next question for us here in Europe is that how much variation is there between the different European countries? And here we compare 5 different biobanks with European ancestry individuals, 4 from Europe and 1 from Boston. And you can see that there is much less variation compared to the African ancestry groups and Asian ancestry groups. And for some of the diseases, there actually surprisingly little variation, given again the fact that there's some variation in how these individuals were ascertained for these biobanks, and there's age distribution differences, and there's all kinds of differences in the background. In other words, the polygenic risk score seems to be pretty robust within the European differential healthcare systems and differential biobanks, but the problem is really when we go outside of the European ancestry individuals. One additional comment related to polygenic scores and its behavior is the sort of the question that we hear often, which is the fact that why bother with these individualized or polygenic score estimates when we have a wonderful tool that you can ask from the patient or the individual, and that is the family history. So wouldn't it make sense to simply ask family history and forget about this nonsense about these genetic markers? And we have been looking at this question a little bit in the sense that we have looked at some of the cardiovascular disease endpoints where family history clearly has a role, but where also polygenic risk scores have a clear dose response in terms of the risk. And we asked the question, if we put both of them into the same model, how do they sort of eat up each other's explanatory power, if you like? If we adjust for family history, is there anything left for polygenic risk score? And this is a comparison of the two measures. So on the left-hand side, we have the family history effect for atrial fibrillation, hypercholesterolemia, venous thromboembolism, CAD, and hypertension. And you can see that the risk estimates for an individual with the first degree relative in our data set with the disease or with the diagnosis is between 1.5 and 2. So how does that compare to polygenic risk scores in the top 10% versus the rest? You can see that overall the risk estimates are larger in the polygenic score side than in the family history side, which probably makes sense. These are, after all, measures from the individuals themselves. The second, the diamonds show how the PRS estimate is when it's the only variable in the model, and the box says when we adjust for the family history. And what you can see is that the family history really doesn't modify the effect of PRS that much. So as a sort of a take-home message for this is that yes, both family history and polygenic score has relevance when measuring the risk, but they're not at all measuring the same thing, which makes sense. I mean the family history is, of course, a sort of a surrogate for many kind of processes, some of which are genetic and many of which are non-genetic as well. So, learned so far, it makes sense to combine genetic risk with clinical risk factors when available. It makes sense to combine polygenic risk with rare high-impact variants when available. These are kind of no-brainers, but at least now I showed you or quantified the role and showed how they behave in real-life data. It definitely makes sense to run more GWASs in non-European ancestry groups, particularly in Africans, to be able to estimate risk for everyone. And I think this is an important point when we talk about translating these estimates into healthcare, that if we want everybody to be able to utilize these, we need to do better than only analyze European ancestry individuals. And it makes sense to forget the idea that family history is a good surrogate for genetic risk. It really isn't. Okay, and then I'll wrap up with the last points here. Is that's all good, but does it make any difference to communicate the risks back to individuals? I show you one example where we've done that, and that is a gene risk study, which we are driving with Elizabeth Vidén, whose figure you see there, where the primary aim is to assess whether genome-based disease prediction can improve prevention of cardiovascular disease. And in 2015, we started to recruit over 7,000 individuals, middle-aged, randomly sampled Finns in the south of Finland. Everybody went through health checkup and laboratory analysis. We assessed the risk for everybody, including the polygenic risks, and returned the information using a tool we called CardioCompass. These were sort of typical middle-aged Finns. About 1/4 of them were in high risk due to either pre-existing condition or because of the risk estimates that we provided them. And this is the tool CardioCompass we utilized to communicate the risk. We showed where they are in sort of absolute risk terms, both with sort of traditional risk factor calculation and with genetics taken into account. We showed how they where they are right now in their life, but also made a prediction how their risk changes over age if they keep doing the same or living the same way that they have lived so far. And we provided them the opportunity to toggle around with the main risk factors that go into this system, including, for example, here showing that this individual is a smoker. So we showed how would a how does the risk behave in an individual who is otherwise similar to the person in question but doesn't smoke? And you can see that the risk is much lower there. We asked people how did they feel about receiving the information. Almost everybody felt it was useful. Some 1/3 said that it was concerning information. Almost everybody who participated believed that both genetic factors and their own lifestyle matters in these facts. About 90% said that my personal risk information motivates me to take better care of my health. And interestingly, more than almost 80% say that clinical doctors know how to interpret and utilize genome information. So that's interesting, and I'm happy to tell that to doctors. So in the high-risk group, about 43% of them did some kind of intervention after getting the information. Some visited doctors, some lost weight. We put them on scale and checked. Some quit smoking and took health coaching. And when we looked at what were the predictive factors leading to these actions, it was pretty clear. Females were more active in doing positive health behavioral changes than males. Level of education mattered. Highly educated individuals were more active. And both traditional risk factors with elevated risk motivates to take action, and polygenic risk score worked similarly. So our take-home message was that if you're in the high-risk group, for most individuals, it doesn't matter which route you end up there, whether it's because of your cholesterol levels or whether it's because of your other risk factors, or whether it's because of the polygenic score. It is the fact that you end up there with some route that matters, and higher risk leads to higher likelihood of action, regardless of the source of the risk. So polygenic risk score in this setting at least seems to be working similarly as any other risk factor does. And I think with this message, I will stop. I'll thank or acknowledge Nina Mars, who has done the heroic effort in the polygenic risk score work that I presented, Elizabeth Vidén in the gene risk study leading there, and the FinnGen community who has provided many of these opportunities. And now I'm very happy to take questions or hear your comments.
Thank you so much, Samuli. So I'll ask the panel to hold their horses for just a little bit while we do some questions with just Samuli. And the first one is from Espen Agerbo. What about the design? Often individuals are highly selected with the risk collider bias or just case severity biases.
So now I think the answer depends on a little bit of which part of the talk you refer to, but in the FinnGen data, so if we start from there, but maybe this applies to much of what I presented, is that FinnGen is a combination of population-based randomly selected cohorts as well as a clinical biobank samples. The population-based samples are more or less population-based. Of course, there's always some participation rate issues, but particularly the older Finnish cohorts are very well representing the Finnish population with these diseases. And the clinical biobank samples are more selected. So all of these results that I presented, we've always have a sort of a second set of cohorts which are the population based. So even if we use in the original analysis the whole FinnGen, we try them out in the population based setting as well, and as a sensitivity analysis. So there shouldn't be, or at least the likelihood of these types of biases are much smaller when modeling the risk of getting the disease. Now, there's obviously much interest also to move ahead from there. So trying to understand how to utilize these types of tools also for prognostic purposes. So maybe you have the breast cancer diagnosis. What is the value of germline variation in predicting the future, sort of the best choice of best treatments and the follow-up and relapses and so forth. And that's obviously where many of these questions of collider bias type of well-known epidemiological issues come into place, and we need to be really careful on how to take those potential biases into account and how to adjust for them the best we can.
On slide 15, Abhishek Chowdhury asks, you explained why clinical risk scores are more accurate for older individuals, but why do you think polygenic risk scores are less accurate for older population compared to less than 55 years old?
Let's see. So we are talking about this one, I think. So that is a good question, that is actually a very good question, and we don't quite know, other than maybe coronary heart disease, which is a disease that accumulates over a long period of time until we have the event that is calculated then and captured by our measures, myocardial infarction or similar type of less severe events. So maybe it is that we are all on the path to the disease event on some rate, and it's the genetics that puts us to some of these paths. Some are more rapid and some are more slow, and it is the earlier onset diseases that are more driven by our genome or our risk in the genome. And as we get older, we accumulate other type of exposures that are non-genetic, and they become more prominent. So this is what many believe is the dynamics here. I'm not sure how well sort of directly that has been shown, but this is an example of a result that supports such a hypothesis.
A question from Mohammed Nawaz, based on PRS distribution, can you compare two tails to find some orthogonally acting associations, such as the sequence variants that may help protect?
I think yes, absolutely. So definitely, I'm not quite sure what exactly do you mean, but I can imagine that with polygenic, if I have a very high polygenic risk for a disease, but I don't get the disease, so maybe it is helpful to study people like me to find the protective variant. So that's a sort of a design that have been suggested in many cases, particularly at the times when sequencing was very, very expensive and we couldn't sequence large numbers of individuals.
Lone Sunde asks, could you speculate when will Finland leave the age criteria for mammography and use polygenic risk scores instead?
Well, that would be a discussion for the panel as well on how should we move forward with these types of results. I mean, breast cancer is only one example, but maybe it is a good example in the sense that we have there's an existing protocol, and the question is how to modify that and what is needed in order to modify that. But I of course don't have an answer, but it is a very good question still, and maybe that sparks some discussion in the panel.
I think that's a good cue then to go to the panel discussion. So we will, you can stop sharing your screen, and the panel can please turn on their cameras and microphones. And I will ask Kári to take the first word, and then perhaps after Kári, Juni, and then Andres, and then back to Dan and Patrick.
I think that the big question, there are a lot of questions about technical, theoretical aspects of risk assessment and how it should be best done, etc. But the really pressing issue today when it comes to these risk assessment is how they can be applied in clinical practice. How can we use them to decrease the load on the healthcare system? How can we use them to make a paradigm shift from interventional to preventive medicine, etc.? And it's amazing where you run into resistance when it comes to doing that, because the medical profession is probably the most conservative profession in the universe and is not necessarily jumping up and down of happiness with these kinds of instruments. But when you begin to look at, we in Iceland have been doing a lot of genotyping, a lot of sequencing, and when you just look at the data in existence in Iceland, we have started to be able to, even if you just take, the mutations that are called tier 1 and tier 2 mutations by the American College of Clinical Geneticists, we can find probably about 5 to 6% of the population that carry these mutations. They can be found, and you remember these are the actionable mutations, and they lead to an obvious avenue when it comes to taking advantage of them. But still, it turns out to be difficult to get the community to take advantage of it. So I think that we as scientists, we have a substantial task ahead of us to lobby the politicians and to convince the population to use this. But there is little question that work of the type that you guys are doing in Finland and we have been doing in Iceland will drive substantial changes in the healthcare system within the next 10, 15 years. But how close to us in time is going to be depends on how hard we will lobby the politicians and how well we manage to tell the story to the people in general.
Yes, I totally agree. And not only, I mean, the politicians we need to lobby, but we also need to find the key clinical people who believe, maybe from the younger generations, or maybe I don't know how to find them, but I'm sure you have done a lot of work in trying to identify those as well.
Samuli, it is not just the clinician, it is the way to tell the story to the people in general. We are not just eccentric, crazy scientists who are eager to probe into their personal lives, try to figure out, where the strengths and the weaknesses lie. We are simply trying to figure out a way to make the healthcare more preventive, more effective, cheaper and better, right? And the population in general hasn't completely bought that.
Juni, would you like to make an initial comment?
Yes. Can I hook up to Kári's comment and really ask Samuli, because thank you, first of all, for a very interesting talk and for a very serious effort to bring genomics into clinical practice and show us how this could be done. Now, in Finland, how has this been received? Do you feel that you've sort of you talked about the patients, if you like, getting their risk estimates, but what about the policymakers and the clinics? Are they answering to your excellent efforts to bring this forward?
Well, I think yes and no. So it's sort of small steps, and finding for us it has been, the key has been finding a couple of key players who listen to as Kári said, us slightly crazy sounding scientists, even though we are probably not that crazy. And then finding the use cases where we can really show the benefit. And that's been, and I'm not saying that we are far from, doing this in a big way, but these two diseases that I spoke most of, cardiovascular disease and breast cancer, breast cancer is a good case in the sense that there is a understanding of the role of genetics because the mutations have been around for a long time. Now we need to teach that it's not only mutations, there's other genetic variation that matters. And we need to think about how then to bring maybe to the existing routines this other information, or maybe we need to develop new ways of communicating these individuals. But take a breast cancer patient, an early age breast cancer patient. We have a routine to start contacting the healthy family members of the case. It's a little bit different routine if the person has a mutation and if she doesn't, the index case has a mutation or not. But this is an existing routine. Now tapping into that and showing that that polygenic risk, for example, has a clear relevance here, and it changes the game because so many more cases have high, not individual mutation, but high genetic load. If we can get through that, then we could, of course, continue and say that because this works for breast cancer, why not do the same for diabetes or primary prevention of diabetes on population level as people are getting more and more obese. So I'm not sure whether it's a sort of a revolution on the grand scale or whether it's identifying the best cases where we can make a difference to a big number of individuals and utilize those as our poster children.
Can I ask a following question? I'm trying to think of the situation in Sweden and if there is this kind of discussion. I'm not so sure there is. And I would like to ask about the FiMM study. How much has that triggered the material that you're using in setting up these examples of using the risk score? And what I will come to after that is that important is that there is really access to both high-scale genomic data and data on the population level for the disease outcomes. So FiMM, how important has that been?
Well, obviously the first part couldn't have, we could have done some of it in UK Biobank or with our friends in Estonia or in Iceland. But it is, of course, it's important to have a database to test out how these risk models behave in each population. The populations are different in their baseline risk for many diseases. Some diseases we have much more in Finland than, say, in Sweden, and others we don't. There's actually differences between East and West in Finland for many diseases, as you well know. And much of this, you cannot really estimate these things unless you have a good, solid reference population database, because even though my argument was that the polygenic risk scores behave similarly across Europe when you have European ancestry people, individuals, that is actually given by the fact that there is a biobank in all of our examples in the background, so that we can scale these scores to fit into a Norwegian population distribution of the genetic variation or Estonian one. So in other words, I think Sweden has a wonderful set of research cohorts. But this needs to be sort of
assembled into a coherent something which is easy to use. That's what you're saying. And this is being discussed, but maybe not so much on the prevention side and risk scores for attracting a disease, more from the treatment side, I would think. So there's still homework to be done. Thanks.
Shall we go to Andres and then back over to Iceland so everyone gets an initial chance to talk here?
Thank you, Samuli, for a very nice talk. So I also go into this prevention side and how to really transfer this science, which I think we already have enough evidence that PRS can work, but lots has to be still to be done. But what we did, you know, Kári is very right that doctors are very conservative, and the most difficult thing is even not to change the politician's mind, because this we did, they are really funding us, and recruiting 20% of population into our biobank, and everything was covered by Minister of Social Affairs, fine. But to convince doctors. And so we did three things, 2 hospital-based projects, coronary heart disease and breast cancer. For CARD, we trained about 10% of our primary care providers. And so we just did the study. Study will be over in March, in 2 months' time. And we already see the same thing what someone was pointing out, that for young people, polygenic risk score is the only risk, because they don't have elevated cholesterol, blood pressure is still okay, but genetic risk is very high. So cardiologists actually, as they are now convinced that actually this is very useful. And you know, at the beginning they were thinking, you know, it's just like another project, but now they would like to do it. And also, other project we did with cardiologists for FH, you know. And FH, we just picked a high loss of function mutation from the biobank, and you know, they went to the hospital, and you know, most of them got diagnosed. They are all under the screen. They just, the FH people going around, and nobody recognized them before they just end up in emergency room. Breast cancer, the same thing, but oncologists are working, not GPs. And they also found that we invited them back to the hospital based on polygenic risk score, and they, even the project is only like a little more than 2 years, they found new cases, and they all were less than 52 years old. That means they are getting younger ones, which they don't see if they do the mammography in normal ways. And finally, we invited 3,000 people to a biobank and hired medical geneticists and doctors just to interview them and return the data back to these people. And also we did questionnaires before and after, and 6 months later, how they like it. And we had the same results, that people actually liked it. And people were really, you know, pretty normal. They took it as normal. Ethics committee was very against of this project, that people get too nervous and anxiety goes up. Nothing like this. People are quite rational, and they got 20 minutes of counseling. So I would say that the most convincing way to win doctors over is just to show the data. So they have to see that this is something useful, which they don't see if they are not using genetics in their everyday practice. And I can add one thing. Tomorrow is a worldwide cancer day, and the European Union is putting forward a thing which is called Europe Beating Cancer Plan. And this Europe Beating Cancer Plan got input from Mission for Cancer, which was another thing, kind of new thing. And now in this document, polygenic risk score is prominently presented. So this is kind of political document which tells to, in northern countries, we don't have to be convinced as scientists, but you know, go to south. And these countries have to now think, look, Europe is proposing and also will fund it. So I see that this genetics is going into common complex disease field much more prominently. And they also quoting other thing, which is a 1 million genome project. And so I think that Brussels is going to support full genome sequencing across Europe. The first plan is just to sequence 500,000, but by 2025, probably 5 million. So that means that people have to sequence, they have to analyze I have to learn how to analyze the sequence. In northern countries we know, but go down to the Bulgaria, you know, they are not very good yet. So they have to learn. And now I see this Europe plans to spread this knowledge across Europe, and I see it's a very good thing also from political side. Thank you.
Samuli, did you want to respond? Or let's go over to Daniel and Patrick for their comments.
Yeah. Thank you for your presentation. I just quickly want to talk about one point that you referred to a little bit that I think is important, and that is the importance of having a good local set, both for scaling the risk score, but I think also to understand and classify the rare variants that are propagating in the population, because on an individual level, for example, take BRCA2. I noticed that in one of your slides, for example, the BRCA2 risk was only annotated as slightly bigger than the PALB2, which I think is false. I think that's because that risk estimate is diluted by a lot of false positive BRCA2 variants. The true BRCA2 at-risk mutations, they have a substantially higher risk than the PALB2 mutation, for example. So I think it is very important for applying these polygenic risk scores to have a local set. And I think for prediction, you also you can throw out the worry about capturing risk stratification and things like that. Obviously, you need to care about that for all kinds of epidemiological questions. But just in terms of risk prediction or risk assessment, then it's not much less of a worry. So I think as we move forward, having very good, well-characterized data sets from every population is going to be very important for applying polygenic risk scores locally. Based on whole genome sequence data.
Maybe I just quickly comment that I totally agree. And it's not only, we can divide population into smaller and smaller pieces, and maybe we need to do that at least for some of the rarer variants, but then there's all the admixture going in and how to model that. So we really need to understand also, so we need to understand the dynamics of the population genetics in the background to understand really how these variants and polygenic scores mutations and polygenic scores work together. Yes.
So we've been discussing, and I'm gonna, bounce on what Kári was saying at the beginning. We've been discussing about how to return genetic information, and we can more or less separate it in two parts. The monogenic disease that are relatively simple to comprehend and simple probably to communicate, and that put you at one end of the spectrum. And you have the polygenic risk scores that are maybe more complex to understand, maybe a little bit less powerful to put you at the end of the distribution. It's going to put you somewhere in the middle often. So I think very likely, or at least we've been discussing with Daniel before the meeting, very likely the polygenic risk score and the common variant could be an incremental step once you start trying to communicate the kind of more straightforward variant. I think if you don't succeed to communicate this variant that are kind of already accepted as actionable and with a high penetrance, trying to do the more complex stuff might be just very difficult.
So when you're dealing with rare variants, you're helped by the heritability.
Yes.
That you're losing a lot when you go into the polygenic risk score.
Yes.
So the family history helps you to keep the nose to the grindstone. So it's a different issue.
A simpler notion to communicate. So we think it could be one way, one step toward kind of a full communication of the genetic information would be to start reporting the incidental finding based on monogenic. Most of the time it's for the same condition, cardiovascular disease, cancer, but I think it could be a middle step or at least a foot in the door of trying to communicate, because it looks to me that going straight to the complex polygenic or to the polygenic risk score based on this maybe cryptic calculation is a larger achievement than going to this monogenic first. It's one way to present it, I think.
True.
But I think what Daniel was bringing up before is an absolute key, that once we begin to apply this to people, flesh and blood, in our community, we have to have good local data. Absolutely, because otherwise we will begin to unnecessarily scare people, and we will be, hanged in the highest tree when we begin to do that. So I think that gathering large amounts of local data is necessary. You cannot pick something out of the literature and use it. You have to do the groundwork at home.
Juni.
Yes, thank you. Can I change gear a bit? Because we talk about clinicians, we talk about, or I want to talk about education, because it's not easy to grasp this polygenic risk score, and it's even less easy to actually do computations to understand what it takes to apply algorithms, etc. So I'd like to ask Samuli how you look at the education in this very broad and complex and very important area. You have these computational scientists, you have statistical scientists, but these days you also have data scientists, and you have people who have the buzzwords of artificial intelligence written in the front of their eyes. How should we educate to get this, these concepts that you are talking about and we want to bring out into the medical profession as well? How should we set up education in the universities?
Well, that's a small question.
Just a few comments on that. I know you're right in the middle of it. You're in a medical faculty, but you have your own education from elsewhere, and it's not getting less complex with data science and AI coming in.
So the people that seem to sort of thrive best in these types of questions are either highly computationally oriented MDs, or they are sort of a computational background, but enough sort of knowledge and interest in biology. So it's not enough that you learn from the books, but the biological questions and epidemiological questions that I mostly talked about need to be something that really drive the curiosity of those individuals as well. So I think the big question is, how do we educate people not in a narrow-minded way, but rather to embrace both the medical side of things and the computational side of things.
Can I just comment on this, because I think it is extremely important to recognize that the task, it has two major components. One of them has to do with how do you educate the physicians to take advantage of this, and that is relatively simple matter, because it should be, you're going to be presenting to the physicians the numerical value to risk, all right? And that's not going to be generated by them. That is generated by other people through all kinds of instruments. So we shouldn't be this constant hampering on the difficulties in implementing these things, because the medical profession is not educated to understand this in detail. The medical profession has never understood in detail how we calculate our risk, for example, how elevation in cholesterol leads to increased risk of heart disease, etc. The medical profession has been focused on the numerical value to risk and the methods used to contain the risk. The other side to this is the question, how do we educate people to become scientists, to work on this, to develop instruments for the physicians to use, so they can approach the problem in a relatively simple manner. And I think it is very important to, at least in practice, keep these two things separate.
I agree.
I agree as well, but the young people, how do we educate cascades of people within disciplines to actually take these things seriously? I'm thinking of the young ones. I'm thinking of how universities should set up education systems, or at least trigger young people to see that there is a benefit to look across from different science domains to another.
May I comment? So I believe that we have to start from medical school already. And of course, we have to retrain a little bit doctors who are working today. But I give to our primary care providers always these examples that take look NMR. You know, they didn't have to learn physics before the NMR came. The only thing they had to read was 2 lines from the report, you know, what the radiologists are writing. So I believe that this is the same thing. You know, there is a complex mechanism and techniques behind this decision support systems. But at the end of the day, the primary care provider gets a report, and the most important thing is just to convincingly transmit this information to the patient, that patient can change their lifestyle or take a pill or whatever the patient has to do, improve their life. So I don't think that we have to wait when the next generation of the medical doctors are coming out of university, or they get genomic medicine and personal medicine as a discipline. So I think it's, you know, I would say that if results are positive, doctors are seeing that it helps the patients, they will learn and they will come along.
If I could interject, there was a comment made on the side here that I think is a little bit relevant. In prenatal diagnostics, Luna Sunde again says, in prenatal diagnostics some years ago, we moved from an age criterion for prenatal chromosome analysis to a combined risk score calculated from 4 factors empirically shown to influence risk of chromosome error in the fetus. And everybody, doctors that is to say, were happy when we showed that the frequency of prenatal analyses went down without losing sensitivity. There's one other question I just wanted to add. It's from Juni Wilhelmsson, and he asks, Samuli, you tried LD-PRED and PRSCS, and he says they've now addressed issues raised about LD-PRED in a paper. And they, which LD-PRED 2 outperformed PRSCS. Would it make sense to try that as well?
Absolutely, Bjarni. Very good. Definitely, yeah. And I've heard many good things about your next version of algorithm.
Moving around the panel, any other comments or questions?
I say my last comment is that the main thing is, if we would like to get something out of this population-based healthcare, that means we have to do population-based screening, because otherwise it won't give us the results. So that means a newborn screening, which is happening now in already how many years, half a century. So we have to get this paradigm shift that actually adults has to be screened also. But this is something, you know, I don't know how we can convince. We'll see that about 75% of people in Estonia might take this test, but 25% I don't think they do it. You know, I don't know when they are going to do it. So this is a big thing. If we want to get this polygenic risk score into population base and find out all these high risk people and offer intervention, then we need large numbers. No, it's not like thousands. We need major. We need more than half of population, and then we see medical system can see the benefit, reducing the cost and extending non-disease life years. And this big thing. So I don't know how this will happen, how long it will take.
But I think maybe the society could have some role in. I mean, we are always. I mean, one of the documents we are all referring to is the American, or the list of actionable genes from the Medical Genetics Society. But maybe it would make sense for us to start putting together a Nordic recommendation or Nordic. Mm-hmm. You know, list that would sort of why do we need to lean on the American one?
Brilliant idea, brilliant idea.
So there's one thing I wanted to say. For example, if you look at it, the factor 2 and the factor 5 have been known for very long to be risk for thrombophilia. I'm just going to finish it quickly, and it's not been discussed before because it was too expensive to systematically test. But if you have the result, you probably would use it, at least for the homozygous.
Samuli, the reason we have been using this American list is that we have been told that the Americans are reasonable animal model for Homo sapiens. That's all.
Doing more work there is different.
Any last comments since we're getting very close to the end?
Why don't we just call this an end? and go home?
I'll make a comment if you don't mind.
I really mind that, seriously.
It's relevant to Juni's and your debate about the value of how much time should be spent educating physicians, and I do think that one reason to educate physicians about the basis of this is that they will communicate that to society and they will field questions from their patients. And so I wanted to mention that Kári and several other members of society have been contributing to the first first course in personalized medicine from a Nordic perspective, which will be a MOOC, massive open online course at Coursera. It will launch in the fall. It was came out of the meeting with the Nordic deans last February, where there was an offer to fund this pilot course for last year medical students. And it's produced by the University of Iceland and the University of Copenhagen, together with input from some of our officers. And the idea is that it can serve as the basis for other courses, as Juni was saying, other people in graduate students and maybe practicing clinicians as well. So it's the first step.
Very good.
With that, I think I should say thank you to Samuli and to our panelists and to Nico, who keeps us going, and to all of the attendees. And see you soon for another one.
Thank you.
Bye.
Bye-bye.
Bye.
Thank you very much.